All right. Thank you very much. Yes, good evening once again. My name is Sadat Katama, and I'm a psychiatrist. Welcome to yet another episode of our Neurotorium Educational Series, where we are looking at the neuroscience understanding of mental disorders, common mental disorders, and how this should be applied to drive diagnosis, management, and the referral for patients with mental disorders. So this is week 3 of our series. And in the first week, we looked at depression. In the second week, we looked at depression was done by myself. And in the second week, we looked at substance use disorders. And this was presented by Dr. Raymond Mugume. And in this week, we have Dr. Andrew Muyanga, who will be taking us through the neuroscience of schizophrenia. Today, we shall be looking at the definition, some epidemiology, some presentation of schizophrenia. Much of the information that we do use is provided on the Neurotorium website, which is actually free to access. And you can actually just check with the Neurotorium website. You just go to neurotorium.org and you will find all the information. So just to briefly take you through what happens. So when you go to this website, neurotorium.org, and you click on it, you're going to find this site. And from here, you can go ahead and navigate the different themes that you might want to look at. There is anxiety, depression, Parkinson's, bipolar, stroke, Alzheimer's disease, substance use. So when you check on the old themes, you're going to find all these other conditions. You'll find stroke, migraines, substance use, Alzheimer's, depression, schizophrenia, and others. When you reach here, you can access all the presentations or the slides which have already been duly prepared, which you can actually use. These resources are free. You can use them for your own personal reading, for discussions with friends, or even when you want to use it to explain something to a patient whom you might be seeing. And in preparation for exams as well, I urge us to sign up for the newsletter here. When you go down, you're going to find sign up for our newsletter. And then when you click on this, signing up for this newsletter is entirely free. And you can get updates based on what is happening. If some changes have been made to either a presentation or they have uploaded more content, you'll receive an email that is going to alert you of what is happening. Most of this content is updated based on new research that is being done, and it is really important that we keep up to date with whatever is going on in the world of research to inform our decisions for the patients that we see. So I encourage us to sign up for the newsletter so that we can access this information. When you go to this Neurotorium website, so many things happen. There is a brain atlas where you can actually see what happens within the brain. If you want to study a particular part and you open it, they are going to show you the brain, that particular part that you have, for example, asked for, and then you can look at its relation to other structures. You can have a better understanding of this compared to where you just read it within your brain and you're probably looking at the 2D images in the textbooks. But now this one, you can rotate this thing very well. You look at the mesencephalon, you can try to rotate it around from all angles, and then of course you read something about it. And if you need to check a particular brain part, you can just type it in. So this is what Neurotorium is capable of doing, and I urge us to use these resources. Today, Dr. Mark Andrew Muyanga is taking us through schizophrenia. We want to understand what goes on, how do these patients present, and what do we need to assess them, how should we suspect, and then later on, we shall be seeing how to manage that as day. So allow me invite Dr. Mark Andrew Muyanga. However, at the end, we shall have a poll, which I urge that all of us should complete. And also, we have CPD points for members who will have registered and have attended for a particular period of this session. Dr. Andrew Mark Muyanga, you're welcome. Thank you.
Thank you very much, Dr. Katama, for that introduction. I hope I'm audible.
Yes, please.
All right. Just give me a few minutes to quickly sort this and we kick off. So my name is Dr. Mark Andrew Muyanga, and I am a newly minted psychiatrist from Makerere University College of Health Sciences. And we thank you so much for sparing time to be with us to go through the content that we are going to share. So today I'm giving us the introductory part about schizophrenia. So if you had lived about 3,000 years ago in ancient Egypt or Greece, hearing voices or hearing your ancestors speaking to you would probably have been seen as a message from the gods. Mental illness back then was blamed on, bad spirits, imbalanced humors, and so on. But over time, as the centuries passed into Middle Ages, society's fear of mental illness actually deepened. And those who behaved strangely, if you reported you were hearing your ancestors speaking to you, or you were seeing things other people could not see, you are behaving in a bizarre manner, those people would either get locked away in monasteries or asylums. Some would be prayed over, as you can see within this peak. And others, unfortunately, used to actually undergo experimental treatments such as being bled, and some, when everything failed, would even be chained. So fast forward to the 1800s, a German psychiatrist who was called Emil Kraepelin noticed that a group of patients whose thinking and emotions slowly deteriorated over time were among the general group of patients he was seeing. And so he called this condition of thinking and emotions slowly deteriorating dementia precox, which refers to early mental decline. And for the first time, mental illness was actually being described scientifically rather than spiritually. Then in 1911, a gentleman called Eugene Bleuler, who was a Swiss psychiatrist, gave it a new name. He called it schizophrenia. And that comes from two Greek words, the first one being schizo, which means split, and the second one being phren, which means the mind. However, it's important to note that Bleuler actually didn't mean a split personality. Rather, he meant a splitting of thought, emotion, and behavior, or a mind that is divided within itself. And he went ahead to further summarize it with his famous 4As, which are affect, association, ambivalence, and autism. But we shall not dive into that today. So the mid-1900s came with a clash of ideas. There's a great and famous psychiatrist called Sigmund Freud, and his followers said that schizophrenia was actually the mind withdrawing into fantasy. But others insisted that it was a disease of the brain. And then in 1952, A single discovery, that is chlorpromazine, changed everything. For the first time, medication could actually calm psychosis. And so this ushered in the age of modern psychiatry. And by the late 20th century, science began, to connect the dots, brain scans, genetics, cognitive studies, all these revealed disrupted neural networks. So the idea of a split mind slowly gave way to one of disrupted what? Integration. And then the DSM and ICD have over the years further refined how we diagnose and understand schizophrenia. So schizophrenia is a condition that changes how someone thinks, feels, and experiences both himself and the world around him. So a person may hear voices or hold beliefs that seem strange to others, and yet to them, it actually feels very real. And it often affects this person's ability to study, to work, or relate with others. And sadly, people with schizophrenia actually tend to die younger. And it is often from illnesses that we could actually have prevented if we had paid attention. But looking beyond the illness, stigma and discrimination make life much harder for these people. But the reality is schizophrenia is a treatable condition. And with the right medication, support, and understanding from family and society, recovery actually is possible. So schizophrenia is defined by a combination of symptoms that affect how a person thinks, perceives, and behaves. And one of the symptoms that schizophrenia has is delusions, which can be defined as beliefs that remain firm even when there is clear evidence against them. If you found me on the road walking naked and I tell you that I am Muhoozi Kainerugaba, no matter how much evidence you try to give me that I am not, by virtue of the fact that there is no SFC around me, I am walking naked, and honestly, I'm not as handsome as he is. All this evidence stacked against me will not convince me that I am not Muhoozi. That is a delusion for you. So delusions can take many forms. For example, believing that one is being persecuted, one has special powers, one has a special position in society, or that outside forces are trying to control their thoughts. However, the other symptoms experienced within the context of schizophrenia are hallucinations, which are experiences that feel completely real to the person who is experiencing them, but they occur without an external stimulus. And the most common example within the context of schizophrenia actually are auditory hallucinations, where a person hears voices others cannot hear. And then there are other symptoms. Someone can have disorganized thinking, disorganized speech, where thoughts have totally lost connection. And once thoughts lose connection, because our speech comes from the way we think. So once the thoughts are disorganized, speech automatically becomes hard to follow or becomes illogical. And some individuals show disorganized or abnormal motor behavior, such as unpredictable agitation or catatonia, where the movement becomes either they have very little movement or are totally unresponsive to the environment around them. And finally, we have what we call negative symptoms. So negative symptoms reflect a loss of normal function. A person has reduced emotional expression, is socially withdrawn, has no motivation, and has diminished speech, which is referred to as alogia. So together, these symptoms disrupt how a person understands and relates to the world. And they highlight the need for comprehensive and compassionate care. So this here is telling us about the trajectory of schizophrenia. Every story of every illness begins somewhere. But the story of schizophrenia is one that starts long before the person has any say in it. I mean, two people fall in love, or at least they think they do anyway. And one thing leads to another, and there you are, born with a unique set of genes that you actually never chose. Some of those genes quietly shape how your brain develops, how it handles stress, and how it is able to connect ideas and emotions. So we begin with genetic and developmental risk factors right from childhood, and these form the biological foundation. So certain genes and early neurodevelopmental issues make some individuals more vulnerable or at a higher risk of developing schizophrenia. But as we move to adolescence, as a child grows, they experience social adversity such as trauma, isolation, family stress, the challenges that come with adolescence. And this compounds the vulnerability. So here we start seeing what I'm pointing at here. That is subtle cognitive, motor, and social difficulties. Now, as we proceed along during adolescence and early adulthood, these early impairments can progress into anxiety and depressive symptoms and social withdrawal. And now this over time is what we refer to as the prodromal phase. Eventually, however, or unfortunately, in some individuals, this cascade eventually culminates into what we are seeing up here, which is full-blown psychosis. So that is the clinical stage of schizophrenia. But the key message from this is that schizophrenia doesn't just appear suddenly. It evolves over time through layered biological and social risk. So I earlier talked about negative symptoms, and they are called negative symptoms because they involve the loss or reduction of normal functions such as motivation, speech, or emotional expression. So you have affective blunting, alogia, that is decreased speech, and hedonia, loss of the ability to find pleasure from relationships or activities. Now, we need to be very careful with anhedonia. If you approached Muyanga Andrew Mark, for example, and you asked him whether he enjoys watching Manchester United playing, and he told you no, please do not immediately surmise that I am anhedonic. As an Arsenal supporter, I have zero interest in Manchester United apart from hearing that they have lost a match. So if I told you I have no interest in watching them playing, it is normal. Anhedonia is loss of interest or pleasure in something you used to find pleasure in or which you were interested in. Now, when it comes to positive symptoms, they are the opposite of negative symptoms. They are additions to normal experiences, and this includes hallucinations and delusions. There are a number of hallucinations. The hallucinations can be auditory, olfactory, gustatory, tactile. Think of all the senses your body has and know that you can have a hallucination in that sense. However, something worth noting here is that visual hallucinations are rare in schizophrenia because the illness primarily affects dopaminergic pathways, which are linked to thought, motivation, and auditory processing rather than the visual system. So we need to note that the auditory cortex, which is found in the temporal lobe of the brain, and language processing areas are actually more involved, which explains probably why patients with schizophrenia mostly hear voices. In contrast, visual hallucinations actually would require the activation or dysfunction of the occipital and parietal regions. But these regions have not been found typically to be affected by schizophrenia. So the take home from here is In case you see someone with visual hallucinations, please make sure you ask yourself further whether these could be drugs, whether it could be delirium or a neurological disorder. Please explore more deeply. I also talked about delusions and what they are, that a person has this belief that they firmly hold on to despite any evidence that is given to them, and it is outside the cultural context in which that person is existing. And the most common type of delusion is the persecutory delusion, where someone believes that they are being watched, followed, or harmed. However, there are so many other forms of delusions out there that we need to be cognizant of. Allow me to take you into the epidemiology and the burden of schizophrenia. So schizophrenia may not be very common, but its impact is huge. Globally, it has been noted that schizophrenia affects more than 21 million people. That is almost a half of the population of Uganda. And it is also known that it is one of the top 20 causes of disability worldwide. So on average, about 1 in every 200 to 300 people will experience it in their lifetime. But this number certainly depends on the study that has been done and the country. Interestingly enough, schizophrenia seems to occur a bit more in countries that are further from the equator. And actually, some studies have found that the cases of schizophrenia that are recorded among people that are born during winter seasons or very cold seasons are usually higher than those people who are born in other seasons. So that is, I think, an important revelation to think about. So at Butabika National Referral Hospital, some data collection was done, and it was found out that about 63% of first-time mental health patients in the year 2018 had been diagnosed with a psychotic disorder, with schizophrenia making up a very large portion. And the average age of these people was 29 years old. This shows us that schizophrenia actually mainly affects young adults, and sadly in their most productive years. Then a study which was done in rural Uganda found a prevalence of about 1%, which actually seems to align with our global figures. It is sad to note that there is a huge treatment gap within the Ugandan context of over 80%. The implication of this is that the people who actually need treatment most or need care because of having these disorders never get to receive that care. So the slide we are seeing here shows how genetics influence the risk of developing schizophrenia. In the general population, the lifetime risk of schizophrenia is about 1%. But as we are seeing here, it rises sharply the closer you are genetically linked to someone with the illness. For example, if your parent or sibling has schizophrenia, your risk is around 10 to 15%, as we can see somewhere around here. But for identical twins who share all their genes, the risk jumps from there all the way to nearly 50%. So it is clear from such a study that genes play a very big role within the causation of schizophrenia. But since even identical twins don't have an 100% chance of getting schizophrenia, or let me rephrase it this way, since the reality is that if one twin has schizophrenia, it is not 100% guaranteed that the other twin will have schizophrenia. This suggests that there are other factors that may be involved beyond the genes. So we now know that environmental and life experiences actually matter within the context of schizophrenia. So schizophrenia, unfortunately, doesn't just affect the person who has it. It deeply impacts the family from which that person comes. So we are looking at this, and these were findings from this study, which was done by a gentleman called Awadi AG and colleagues. And this study found that families actually often withdraw socially in case there is someone with schizophrenia from there. They experience more arguments. They face a lot of financial stress. Some relatives to people with schizophrenia become depressed. Others are embarrassed or lose confidence. And normal family activities such as outings or vacations actually get disrupted. It can even go beyond that and affect work or school. I mean, we understand this within our context. We know how families of people with mental illness have been treated in the past in our societies. We are all aware that in the past, actually, they would even bar you from marrying from a family of someone with a mental illness. We'll tell you that is a family y'abantu balalu. That is a family of people with mental illnesses. So the stigma is not borne by the patient alone, but by the rest of the family members. So when we are treating schizophrenia, we also need to support the caregivers because they do carry a very huge emotional and social burden as well. Schizophrenia is also not just disabling to the individual and family. It costs the society as well a lot. It has been noted that schizophrenia accounts for about 1.1% of all years lost to disability worldwide. And because most people with schizophrenia, that is about 73%, are unemployed, the families and caregivers of these people actually carry a very heavy financial and emotional burden. Now, let me interest you in this. Globally, the annual economic loss due to schizophrenia is estimated at about 110 billion euros. For you to better understand this figure, the annual national budget of Uganda for 2025-2026 fiscal year was 72.4 billion Uganda shillings. This is around 17 billion euros. So when we look at this, we come to realize that the global cost of schizophrenia per year is roughly 6.5 times the size of Uganda's annual national budget. Ladies and gentlemen, let that sink in. Schizophrenia has also been found to be among the top 20 leading causes of disability worldwide, with a prevalence of more than 21 million. I had already alluded to the lifetime prevalence of schizophrenia ranging from 0.3 to 0.7%. And now I think it's time for us to dig into the diagnosis of schizophrenia. So I'll start right off by saying schizophrenia, ladies and gentlemen, has no single laboratory test. There are no specific biomarkers in blood work, imaging, or genetics that can actually confirm it. And the diagnosis, therefore, based on that, is clinical. It relies on a detailed psychiatric history and a careful mental state examination. And a positive diagnosis requires a clear evidence of psychosis, such as hallucinations, delusions, disorganized speech or thought. So the symptoms, furthermore, must persist for a minimum duration. So we shall find out about this duration when you are seeing the DSM-5 versus the ICD-11. And there should be no prominent mood symptoms. that would otherwise suggest another disorder such as bipolar, we are aware that people with bipolar can also present with psychotic symptomatology. The grandiose delusions people with bipolar that they have are psychotic symptoms, okay? But even people with depression can actually present with psychotic symptoms. So that would be depression with psychotic features, or what some prefer to refer to as psychotic depression. It is also very important when you've moved beyond the history and mental status examination and ruling out bipolar and depression to rule out other possible causes of that psychotic presentation. It could be medical, it could be neurological conditions, it could be substance use, or other psychiatric disorders that could actually mimic schizophrenia. And one of them, which I'll interest you in, could be autism, but I'll explain this later as we are looking at the diagnostic criteria. So these are the current manuals that we use to diagnose schizophrenia. Initially, we had the DSM-4, but currently we are working with the DSM-5. So the DSM is mainly used in the United States of America, and the ICD is used mainly in other countries, mostly European and so on. So we are currently 2025. We mostly refer to the DSM-5 and the ICD-11. And that is because a number of changes have been made. So in the DSM-5, schizophrenia is diagnosed when a person has at least two key symptoms, which could be delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms. But it is very important to note that one of the two symptoms which I'm talking about here should be either delusions, hallucinations, or disorganized speech, and they should have been present for a significant portion of at least 1 month. The second thing that is noted within criteria B, which we are seeing here, is that these symptoms must seriously affect the daily functioning of this individual. So maybe the person stops working, the person struggles with relationships, the person neglects self-care. So if you are having delusions, but these delusions or hallucinations are not affecting your ability to work, they are not interfering with your interpersonal relations, your self-care, or anything of that kind, then we cannot justify that as being a disorder. And finally, for criteria 6C, and which is actually very important, the overall illness must persist for at least 6 months. Now, this draws the distinction between schizophrenia, schizophreniform disorder, and an acute psychotic episode or a brief psychotic episode. If someone has had these symptoms that we have been talking about for less than 6 months, but more than a month, that is not schizophrenia, ladies and gentlemen. That is schizophreniform disorder. If they have had the symptomatology that I'm talking about for less than a month, that is not schizophreniform disorder. It is not schizophrenia. It is a brief psychotic episode. So criteria C is very important to us. Now, criteria D, E, and F actually help us to make sure that the symptoms that we have been talking about in A, B, C are truly due to schizophrenia and not another condition. So let us look at criterion D, for example. It reminds us to rule out bipolar or major depressive disorders that can also present with psychotic features. And I explained that a little earlier. So people, for example, with um, depression. Someone can have delusions of worthlessness. Okay? Someone with bipolar can have not only grandiose delusions, there are times they can be paranoid. There are times they may feel persecuted. So they can have a number of other delusions. So we need to make sure that it's not bipolar, it's not major depression. Then criterion E is telling us that the symptoms should not be caused by drugs or another medical problem. And that is because we know that drugs at times can can cause a psychotic presentation. Basic example is people who take marijuana at times can be very paranoid, very paranoid. So if someone has taken a drug and they present with all the symptoms noted in criteria A, B, C, that is not schizophrenia, as long as those symptoms happened after them taking the drug. That is a substance-induced psychosis. However, psychotic presentations can also be as a result of medical problems. You have a renal failure, okay? You have a liver failure and you get an encephalopathy, definitely you may end up with a psychotic presentation. Someone at times who is delirious may present as if they are psychotic. So you need to make sure that you have ruled out all these. Now, children with autism. Now, this is criterion F, and I need us to carefully look at this. That children with autism may actually already talk little. They usually talk very little, and they act differently. Some people call it acting weirdly. They also struggle socially. So if you based on this alone and you say this person may be having schizophrenia, you would be totally off. So if someone has a history of autism at any point, for you to be able to say this person has schizophrenia, there have to be additional strong psychotic symptoms, such as hearing voices, them having delusions, and to name. But if you so kindly note this point about autism spectrum disorder or a communication disorder. And certainly there are specifiers, but which we shall not delve into because of time. So you could specify and say this is, for example, a first episode, and it is currently in an acute episode, or it is in partial remission or in full remission. You could say these are multiple episodes, and so on and so forth. So that is the DSM-5 for you. Now, let us go through the differences between the DSM-5 and ICD-11. There are going to be few. So this slide is comparing the DSM-5 and ICD-11 and how they define schizophrenia. The DSM-5 says symptoms must last at least 6 months. Ladies and gentlemen, let us take note of this clearly. The ICD-11 instead says they need only 1 month. Of the major symptoms that we noted in criteria A of the DSM-5. The DSM-5, and this is something which I really appreciate, it also looks at how the illness affects daily functioning, work, relationships, self-care, and other facets of living. The ICD-11, however, focuses more on the symptoms themselves. Personally, I think that a human being is beyond the symptoms they present with. You qualifying me as having delusions, but when these delusions are not affecting my work, they are not affecting how I relate with the people around me. They are not affecting me socially, economically, or professionally. I don't see how that symptom would have relevance. And so on this point, I think the DSM-5 personally, it wins. And both manuals have gone ahead to remove all subtypes of schizophrenia. So we used to have paranoid schizophrenia, catatonic schizophrenia, hebephrenic or disorganized schizophrenia, and so on. But over time, these people came to realize that, yes, today you may go to Dr. Muyanga and all he sees is a catatonic presentation. And so I give you catatonic schizophrenia as the diagnosis. 2 days later, you may have paranoid features. And 1 day later, you may have disorganized features. So they realize that the symptoms keep changing and a person may have more than one symptom. So you can't lock them in one class of paranoid, catatonic, or hebephrenic schizophrenia. And the other difference between the DSM-5 and ICD-11 is that a brief psychotic disorder in the DSM-5 is less than 1 month. I talked about this earlier. In the ICD-11, it can be as far as 3 months. So this is quite interesting, but I'll not stay so much on it. So the other thing that someone may ask probably, I don't know if it is already in the chat, that why would people keep changing? I mean, we had the DSM-3, then we moved to the DSM-4, then we moved to the DSM-5. What is the difference between the DSM-4 and the DSM-5? So in simple terms, the DSM-5 changed how schizophrenia is organized and diagnosed. First of all, the old types of schizophrenia, which I've talked about, the likes of paranoid schizophrenia, catatonic schizophrenia, that were in the DSM-4, were removed. And this was because, as I've already explained, people often move between these types of schizophrenia or the symptomatology. And so they were not reliable. Second, DSM-5 no longer requires strange or bizarre delusions or voices which are talking to each other for you to confirm the diagnosis. No, we don't need that anymore. The third bit is the DSM-5 now looks at mood symptoms across the whole illness and not just one episode. But the final thing I think is in the DSM-4 we had catatonic schizophrenia, okay? But now catatonia has actually been separated and is now treated as a disorder on its own in the DSM-5. So we pledged when we were starting this program that we shall be using strictly 1 hour, that is from 7 p.m. to 8 p.m. And my plan is to stick to that pledge. So I am summarizing, ladies and gentlemen, and after Dr. Katama will tell us what comes next. So I gave a definition, and I said that schizophrenia is a chronic mental disorder which is marked by distortions in thinking, perception, emotion, and behavior. And I also noted that it is treatable with medication and psychosocial support. So there is a mantra out there that has been spread over and over again that schizophrenia has a downward course. Okay? Now, from today onwards, ladies and gentlemen, we need to know that there are people who are treated for schizophrenia and recover and never get another episode. And they don't need actually to continue on treatment. There are people who get treated and become stable, but they need to remain on treatment almost for life, okay? But as long as they are on treatment, they remain very functional. And then there are people, unfortunately, who even when you treat, they continue spiraling downwards. So that statement of schizophrenia has a downward course is not general, and it is not a sentence for everyone who has this diagnosis of schizophrenia. I also noted that schizophrenia has core symptoms which can be broadly subdivided into positive symptoms and negative symptoms. And the positive symptoms included delusions, hallucinations, disorganized speech, disorganized or catatonic behavior. And then
Excuse
the
me,
negative symptoms, yes,
Dr.
please.
Muyanga, please summarize in a minute.
I have 1 minute to go.
I have given you an extra minute, please.
Oh, thank you. I'm almost done. Thank you. So we talked about the core symptoms, we talked about the onset and risk, and then we said that there is no lab test for schizophrenia, but diagnosis is based on psychiatric history and mental status examination, okay? I want to close this by saying that the story of schizophrenia is not hopeless. As long as we detect it early, consistently take treatment, and offer strong social support to these people, we can greatly improve their recovery and their quality of life. Thank you so much for listening to me. Over to you, Dr. Katama.
Wow, wow, wow. This has been so insightful, very interesting, and really mind-catching. I believe that everyone here who has attended is living today changed about schizophrenia, and probably they are going to alert others about whatever is going on this series. Very well executed. Thank you, Dr. Muyanga, for this presentation. And to those of us who have attended, I urge us to tune in tomorrow. Today we've been looking at the diagnosis. Tomorrow we are going to look at what exactly goes on in the brain of an individual with schizophrenia. And it is upon what goes on in the brain that we base to provide our treatments. So I urge us to tune in tomorrow and we continue with these sessions. And for those whom you know that have missed today, you should tell them about how good it is to listen to these sessions. So you should urge them to also tune in tomorrow. Please, I think Dr. Mwangus is going to share the poll, and please we request that you respond to that poll, to the questions on the poll. And if you find that you're not seeing the questions on the poll, please just go to your right and you'll find an icon with more. And when you click on more, you're going to find something called poll, and then you will go to it, polls, stroke quizzes, and then you can be able to respond to poll. For now, I would like to invite Dr. Andrew Muyanga yet again to respond to some of the concerns or questions that have been raised. Dr. Edina Nagadia said that notably schizophrenia with negative symptoms can present as depression. Yes, this is very true, because when you look at the symptoms of the negative symptoms of schizophrenia, and then you look at the presentation of depression, there might be some matching symptomatology, although it will not be very exact. There will be some subtle differences. So, Dr. Muyanga, there is a question which asks for the clear difference between somatic and tactile hallucinations.
Thank you, Dr. Katama. So somatic hallucinations are false perceptions of sensations that are felt inside the body, such as the feeling of one's organs moving, insects crawling under the skin, electricity passing through your body, and so on and so forth. Tactile hallucinations, on the other hand, involve false sensations on the skin's surface, such as feeling touched, pricked, or bugs crawling on the skin. So tactile is on the skin, somatic is under the skin and deeper. If I'm to state it simply, that is what I can say. Thank you.
Yes, thank you very much. I don't think I can add a single word to that differentiation. Then Geoffrey asks about why is the risk of developing schizophrenia high in monozygotic twins? I think here Dr. Muyanga talked about the genes, and you find that the monozygotic twins, they share a very high proportion of their genes, which can put them at an incredibly higher risk compared with those who are like dizygotic or fraternal twins, because of the high concordance, the high sharing of the genes. And you look at monozygotic twins, the risk is about 40 to 50%, while for the dizygotic, we find it at around 10%. And yet in the general population, the risk is about 1%. So I think it is due to the genes sharing the close genes between them. So there's another question here which says, should we wait till 6 months duration to treat as schizophrenia, Dr. Muyanga?
No, 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 no. We treat the patient as they come, okay? Schizophrenia is just a name we are giving the condition, but we are not going to wait for 6 months to confirm that, this person has schizophrenia and we treat. But anyway, as long as we have ruled out organic causes, we have ruled out substances and so on, usually the treatment of psychotic presentations is the same. If someone came with a brief psychotic episode, for example, we are going to give them antipsychotic medication. If someone came and these symptoms have persisted past a month but are less than 6 months, that is schizophreniform disorder, we are still going to treat them with antipsychotics. Not only antipsychotics, by the way. I kindly request you to be with me on Thursday as I talk about the treatment. There is the social element, okay? There is the biological element where we are talking about the medicine. There is the psychological element where we are going to talk about CBT and so on. And there is also the social element. So we don't wait to confirm whether it is schizophrenia for us to treat. As long as we have confirmed their psychotic symptoms, we have ruled out organic pathology and so on, we manage with the antipsychotics that we have available. Thank you.
Yes, thank you, Dr. Muyanga. I hope that response to Pius is really appropriate. Then, Dr. Muyanga, do we still consider the Schneider's first rank symptoms? Your word on that.
So to be honest, Schneider's first rank symptoms are mostly academic. In modern psychiatric practice, they are no longer central diagnostic criteria for schizophrenia. However, they remain clinically relevant as supportive or, descriptive features. If you encountered a patient with schizophrenia and you knew these first-rank symptoms off head, I think it would help you better in exploring this patient and understanding what they may be experiencing. And anyway, you will not get lost. For example, if a patient tells you that they feel that someone is controlling their body, you get that. That is somatic passivity. You will not be lost. So they are important academically. They guide us in history taking, but in terms of diagnosis, officially, we are not using them that much.
Right, thank you. Sandy asked whether DSM-5 diagnoses schizophrenia differently from DSM-5 TR. My answer is no. When you look at the criteria in DSM-5 and the DSM-5 TR, really there is no difference. And this one, the DSM-5 TR is text revision, like just an upgrade of what happened in the DSM-5. So I don't think that is there is any difference. Then people are appreciating the presentation, Dr. Muyanga. What's the best treatment for schizophrenia? I leave this question for Thursday. Please tune in, Dorothy, and you will really be answered. And they say this has been a great presentation. Then there is a question. Josephine Nacha says, I don't know. I know we don't classify anymore, and you clearly highlighted that schizophrenia has a good prognosis. Are there predictors for those who end up with a severe form of schizophrenia, those that don't regain their premorbidity status? Dr. Muyanga.
Dr. Katama, kindly repeat for me that question quickly.
Josephine asks,
Yes.
I know we don't classify anymore, and you've clearly highlighted that schizophrenia has a good prognosis. Are there predictors of those who end up with a severe form of schizophrenia, basically those that do not regain their premorbidity state?
That is quite interesting. Yes, while many people with schizophrenia can recover significantly, especially if there has been early and consistent treatment, there are a number of predictors that are associated with a poorer long-term outcome, meaning individuals may not fully regain their premorbid level of functioning. So one of the predictors could be an insidious or early onset. The other one could be prominent negative symptoms. Then the third one could be poor premorbid functioning. They already had issues even before the onset of the full-blown episode of schizophrenia. Then those who have cognitive impairment, if you lack family or social support, there is poor treatment adherence. So yes, Dr. Nacha, I agree with you. There are a number of predictors. Thank you.
Yes, thank you, Dr. Muyanga. I hope we have all responded to the poll. Yes, people are really appreciating the presentation. Ivan asks, why don't DSM and ICD come up with some diagnostic criteria? I think when you look at DSM is at 0.5, like DSM-5, while ICD, it is already at 11, which shows you that probably ICD has been there even longer than the DSM-5. So they have been classifying conditions for a longer period than the DSM. However, I think this is better because different areas might have different presentations of these conditions. So the diagnosis should also be a bit different. Even the Chinese, they have their Chinese classification of mental disorders, which is possibly going to be different from the DSM and from the ICD. But because it is more localized to the Chinese, we don't really talk much about it, but we mostly talk about these ones because these ones have crossed over to us. Then I think this will be the last question that this is not a question. Dr. Mpamizo says, I have seen some patients with rational delusions. For example, a student who wants to go back and repeat her O-level in order to perform A-level better, and she was already in senior 6. I don't know, maybe Dr. Mpamizo, if you can give us more about these rational delusions.
Yes, thank you very much for the presentation. It was very insightful. Yes, it was very insightful. What I just wanted to say is that there are the obvious delusions where paranoia and all those, but then once in a while, you will encounter a patient who has delusions which are almost rational. So for example, that example which I've mentioned of an S6 student who says she wants to go back to S1 in order to perform better in S6. And she may also have other symptoms of delusions, but the way she's holding that belief that going back to S1 is going to sort all her life in order can be a manifestation of schizophrenia. There are other people also. Someone who, for example, has been working with police, he tells you that, yeah, when I was working in police, I came to know some secrets. I left the police, I'm now retired, but I believe that they are tracking me. There is some rationality in that. It makes sense that he used to work in police. Maybe indeed he saw something which wasn't right and people actually tracking him. That is the only point I wanted to emphasize. But otherwise, thank you very much.
Well, thank you, Dr. Mpamizo, for that response and giving us that example. We are out of time. It is 2000 hours, and I would like to thank everyone who has joined in. For those who are asking about the CPD points, when you were registering, you entered in your numbers, your council numbers, and these will be used to send out to the assigning committee, and then you will be awarded your CPD points. Please join us tomorrow as we look at the neurobiology of schizophrenia, as Dr. Muyanga dissects the brain for us to show us what exactly goes wrong to lead to schizophrenia. Thank you for joining today. Have a lovely night.
Okay. So I think everyone else has gone. Hope I haven't kicked out people who are supposed to be here. I'm not seeing Raymond.
Some of those can miss.
Yeah, I'm not seeing him even in the waiting room. Okay, so thank you so much, team. Good evening to you all again. It has been an exciting session. I think we all still feel the energy. And I'm glad I'm seeing Dr. Mwesiga is here. As usual, the debrief is really to look at the points of improvement, learn some new lessons such that we improve our future sessions. So over to you, Dr. Mwesiga.
I know today I've not been very involved, so I will listen in today. Although I was impressed by at least the numbers were back up, and then also the comments. The people have actually enjoyed the session. So just goes to show if you prepare and practice, things work out well. But we should always strive to improve. We shouldn't say we have made it, because once we become complacent, then we fall. I think that's my feedback. But well done.
Definitely. Thank you so much, Dr. Mwesiga. Thank you so much, Dr. Muyanga and Dr. Katama. I think you have made the session very exciting. Information was shared in a logical manner, and I think you've all seen the responses from the participants. It's been a good session, but as you've heard, it's not the maximum, achievement. We are still aiming for more participation and improvement of all the future sessions. So, Dr. Katam, I'm seeing your mic is unmute. You can go ahead if you have any contributions.
Yes.
Thank you. Okay, so I'm
yes,
going to lock. I'm going to so participants were joining in, so I'm going to lock the meeting. You can go ahead, Dr. Katam.
Yes, thank you, Dr. Mwanguzi. So, thank you, Dr. Muyanga, yet again, keeping time, taking us through everything process by process. It has been clear and very understanding. And of course, the absence of any disturbance or interruption has really made it more easy to follow. It has been easier to follow, I think, for the participants. And I think the way you delivered the information, some people who logged on earlier, and I feel like they reached out at a certain point and other people joined. There was that time when you gave the example of Arsenal, and I was looking at the numbers here, they were in 77. And shortly after that, they jumped all the way to 98. And I noted it, I was like, okay, probably the way you were delivering the information had actually had an impact, or it made people to probably reach out to others and be like, hey, you're missing out on something interesting that's going on in this session. The numbers have been good. The information has been well executed. And I think if we go like this, whereby we do our presentation is in a timely fashion, we organize and keep the time, I think it will be able to maintain the participation, and we need to maintain this kind of thing so that we have more numbers. That is really what I wanted to say. Thank you.
Thank you, Dr. Katama. I think
Dr.
still
Muyanga, if I may
yes.
ask, how is the spread of the participants? Are they still undergrads? Are we getting some more PCOs? If you have that data.
Let me see if I can
I
fetch
think
quickly.
that one will be best answered, but I've also realized that we had some other senior members on the call. I saw Dr. Biravwa, saw Dr. Birungi, Dr. Mizo. They were actually logged on, which shows us the interest that they're actually having in listening to this session.
Okay, I think that's good. I think Dr. Biravwa is someone good to have because she has a big say in the clinical officing school. So if she finds it useful and nursing school, she will surely promote it in those circles.
Yes, indeed. So that one has been really good.
Yeah. Dr. Lillian, do you want to say something? Dr. Lillian had a meeting after this session. I don't know whether you can make your submission and leave.
Most likely she's already in another
Doctor, sorry, I stayed in, but I'm in another meeting. No, Doctor. Dr. Jeremiah, I'm talking to another team. Sorry.
Oh,
Yeah. So I'm not in this meeting. Sorry, I just didn't log out.
Okay. Yes, Dr. Muyanga. So,
personally, I really can't objectively comment since I was the one on the hot seat. But it was interesting. It was interesting. Yeah.
okay. Okay, so right now I cannot get the meeting details just because the meeting hasn't yet been ended. So I think when I end, I'll be able to get to know the cadres that have attended. I'll respond back on WhatsApp, Dr. Mwesiga.
okay, thank you.
Okay.
Maybe just this is not related. On Thursday afternoon, we have an event at the University Hospital. Lunch is at 1, then we have some presentations by the psychosis working group. If you're free, you're welcome to attend. We are sort of like introducing a communication strategy for the department with the psychosis working group as an example of what is possible. But there's lunch. I think that's the most important aspect. And Mwanguzi, don't feel bad. You will watch us eating on.
I was about to
Mwanguzi, you
ask
will watch us.
how I can participate.
With
You
that
can.
lunch, I'm very sure Dr. Muyanga will be in attendance.
Muyanga has other things to do, but other people are welcome.
Thursday afternoon, I will make it a point.
Virtual option.
Okay. Yes, there's a virtual option. So one of the things we want to do is to use social media. That's what I was saying earlier, that we should work with Dr. Chan to upload the last 2 weeks Neurotorium presentations on the YouTube channel for the department for posterity.
Okay. So I
Yeah.
think we can work on that. Either she can reach out to me or I can reach out to her and we see.
I'll tell her to reach out to you because that's her.
Sure,
That's
if
her
you don't
role.
have a contact. Yeah.
Okay.
So I wanted to ask about any feedback about the post test for day 1. Do you feel like there's some question we have to change in any new way of assessing the impact of the sessions? Because the feedback survey we had, in which about 88 participants responded, assessed quite a lot of things which have really given us a better ground for this week. So I don't know whether we need to change some of those questions going forward for the first day post-session poll. Maybe I can relaunch them for you to look through, or I can share the results. I'm sharing the results now, but I think still you can see the questions. Do you think we need to change, modify any new assessment that we have to capture, or we maintain? Sorry.
You're sharing the results.
I'm sharing the results, but the questions I think are also displayed, right?
Yeah, they are.
Yeah.
So for me, I would want us to. I don't want to. I don't want us to feel like we have to what? Keep asking the same question. So like the next poll, can we just maybe ask questions from the content of like today? Why now? Like I had a question on genetic risk. We can ask. So rather than the poll being for our improvement, let's have a poll to see if people are actually grasping the content. If that makes sense.
Okay, so now that means in that case, I would request the presenter, Dr. Muyanga, to compile for me about 5 questions probably for the points that you really emphasized for me to include them in the Thursday session. And I think that has to include like 3 or 4 questions for the content shared today, and then some 2-3 questions for tomorrow's content, and probably like 1 or 2 questions in Friday's content. Really, major take homes. I can compile a poll.
When do you need them?
Best if you could provide them before the Thursday session, such that I compile and then
will.
Thank you. Towards the end of the session on Thursday, they should be incorporated within within Zoom. Okay, any other submissions, comments, questions?
None from me.
Okay. So we meet tomorrow. Tomorrow we are requesting that tomorrow is Wednesday. Dr. Sadat, I think you know the flow still remains. The only thing is that tomorrow we don't have a post-session poll. So we are likely to do, as usual, the 5, 45, 15, but the 15 this time around are going to be for Q&A only. We are likely not to have a debrief tomorrow, just because we are likely to have a meeting with the UAP team that is going to present on Friday at exactly 2 p.m. to take them through how the session is, the flow of the session. So if there's anything that needs to be discussed, we kindly request that we discuss that via the WhatsApp group. This is only happening this week. But also, if we have addressed most of the pressing issues on Tuesday, Wednesday we may not need to meet, unless if there's anything that arises.
Okay, so Muyanga, you can send me the slides again and I have a look. Just such that the slides for tomorrow, if they're ready, and we see.
I am sending them now. I'm sending them
Okay.
now.
Okay, thank you so much, Dr. Muyanga. I think learning points here for future presenters is early preparation, look through your slides, and the time management. I think after I had started the meeting, Dr. Muyanga joined in about 15 minutes, almost 15 before the session, which I think is good for organizing yourself to start early. So I think those are good learning points, and keep it up. Otherwise, thank you so much and have a good night.
Thank you, Dr. Muyanga. Good night, everyone.
Thank you.